Hi there, I'm Yvonne Feeney, and today I'm going to talk about the development of empathy towards people with dementia and healthcare students. I'm based at Centre for Dementia Studies here at Brighton and Sussex Medical School. So I will provide a background to discuss empathy towards people with dementia, give an overview of our conceptual understanding of empathy in healthcare, and provide an overview of a longitudinal qualitative study that I've completed as part of my PhD. So empathy is a core characteristic expected in healthcare. It's mutually beneficial for both patients and for staff. It's associated with better patient relationships, reduced patient anxiety, better diagnostic accuracy, fewer patient complaints, and reduced burnout in staff as well. However, there's inequalities in care which have led to people with dementia often reporting episodes of care that lack empathy and compassion. Once healthcare students qualify, most of them will work with somebody with dementia regardless of where they choose to specialise in their career. So therefore, healthcare education needs to prioritise dementia education to ensure that students have the necessary skills, attitudes and understanding to provide really high quality empathetic care. However, caring for people with dementia can be associated with some unique challenges, and this may impact empathy development. So, for example, patient factors, stigma, cognitive difficulties associated with dementia, and the environment might all have quite a significant impact on the development of empathy in healthcare students. So, therefore, we need to understand how empathy develops. That's a priority for healthcare education. So clinical empathy is a multidimensional construct. It can be made up of affective empathy, which is the subjective experience of another person's emotions. So it's being able to feel what somebody else feels. It can be made up of cognitive empathy, which is an objective understanding of another person's emotions. So understanding what somebody else feels without necessarily sharing in those emotions. Behavioural empathy is the ability to communicate empathetic concern with another person, and moral empathy is the internal motivation to act in a pro-social way. Now, the literature is unclear about a standardised definition which is used in the clinical setting. It can be a variety of these elements. So we're not really clear on how to define empathy in healthcare settings. So there's some outstanding issues. If we want to improve empathy towards people with dementia, we do need to understand how to define empathy in the clinical setting. This has an impact for how interventions can be designed and delivered in the educational setting for healthcare students. We're not sure what factors impact empathy towards people with dementia in healthcare students' education. And we don't really know if it changes. There's a large body of literature that suggests that empathy can decline in students as they progress through training, but we don't know if this happens towards people with dementia as well. So to understand the development of empathy in healthcare students towards people with dementia during their education, I completed a qualitative longitudinal study using grounded theory approaches. I invited medical, nursing and physiotherapy students to take part in this study, and what I did was I completed interviews with them at 2 time points during their training. So right at the beginning, so in their either first or second year of training, and then I followed students up after about 18 months. At baseline, I interviewed 30 students and 26 of those agreed to take part in a second interview. Generally, interviews were done face-to-face. Only a few of them were done in person due to COVID, so therefore the remainder had to be done virtually. I had a topic guide which informed the interviews, and I analysed data using constant comparison techniques. So when we looked at the findings, I will describe here the demographics, students' conceptual understanding of empathy, and also the categories that they identified that impacted empathy development during their training. So most of the students interviewed were female. The average age was around about 27, and the majority of students didn't have experience of dementia when they started their interviews. Obviously, as we progressed to the second interview, all students by that point had some level of contact with somebody with dementia in the ward setting. So students' conceptual understanding of clinical empathy was a cognitive understanding. They felt that empathy was an ability to see a person holistically. It was an ability to stand in the patient's shoes, and they said it was an ability to understand the patient's perspective. They also said that clinical empathy was made up of pro-social helping behaviours, and this was behavioural empathy, so an ability to communicate to gain empathetic understanding. They felt to do this you would need to really listen, be present, use verbal and non-verbal skills, and they felt this was essential to build rapport and trust with the patient. And they said based on this understanding, so this communication would enhance understanding, which would motivate their moral intentions to act in a pro-social way. And they felt that being empathetic towards a person with dementia, you would need to be adaptable, you'd need to be lenient and accepting, and be patient. There was 4 key categories identified which impact students' development of empathy towards dementia over time. These were moral values and principles, the impact from clinical exposure, shifting ideals, and emotional self-efficacy. So all students felt that empathy was a professional duty. They said it was a professional characteristic and an expected trait. They felt it should be provided unconditionally. One should always act with empathy, and they felt that a lack of empathy was unacceptable. They said that empathy was essential for better outcomes, for better relationships with patients, and that empathy helped to motivate pro-social intentions. So they really held these values and principles as being something that were incredibly important in healthcare. However, the impact of the clinical learning environment had both positive and negative impacts on the development of empathy. So first, students spoke about interactions with people with dementia. They realised that patient factors common in dementia meant that it could be more difficult to empathise with the patient. So for example, they felt that sometimes it could be more difficult to understand the patient, to relate to their perspective and to communicate with them, and this hampered empathy. They spoke about the importance of role models. Positive role models were really inspiring and students wanted to mirror similar empathetic behaviour. However, all students discussed negative role models over time, and negative role models and negative cultures had a real significant impact on students' ability to be empathetic. In these environments, they spoke about the need to fit in and keep quiet and keep their heads down, and that had quite a significant impact on them. Students spoke about organisational stressors. They realised that there was a lack of resources and the ward environment was a pretty difficult place at times to be empathetic towards people with dementia. However, interactions with people with dementia over time meant that students felt that their knowledge of dementia increased and that they gained more skills communicating, and they felt that this had a positive impact on empathy development. Then students spoke about shifting ideals. So over time, there was a realisation that there was a discord between theory and practice. At university, there was a real expectation that every encounter would be empathetic. However, students said in the real world, this wasn't reflected. This led to tensions between those moral values that I described a moment ago and the reality of practice, where they realised that empathy wasn't unconditional. They said that you needed to make an active choice to be empathetic, and there was a realisation that staff were different. Not all staff were empathetic, and they realised that a lack of empathy did occur in practice. And this, they said, ended up changing some of their ideals. There was a movement from optimistic intentions to be empathetic, and they realised that actually in reality was very different. They spoke about realising the limitations of being empathetic, that actually it wasn't always possible in the real world setting. And finally, there was an impact on emotional self-efficacy. So over time, students spoke about an emotional empathetic distancing occurred as they realised that being empathetic was associated with uncomfortable emotions. They felt that being empathetic was quite emotionally draining at times. Sometimes they encountered situations which were frustrating or quite sad, or where they felt angry, and they felt that in these situations they were left with negative feelings, and this could impact their willingness to share emotions, or they would become more emotionally distanced. Students spoke about the importance of building emotional walls and leaving their feelings at at the hospital gates and not taking these home with them. On the other side of things, students felt that their capacity for empathy grew as their confidence grew. So as they became more confident, their level of preparedness increased to work with people with dementia, and they felt that this helped to increase their empathy, that they were able to have more of a holistic overview of the patient rather than a very reductionist view of, for instance, the broken leg in bed 3. So when I looked at all of these categories together, I think that empathy develops in the following way. Students have a really, they've got a really high set of moral values about the importance of empathy. However, impacts in clinical exposure have positive and negative impacts on students' empathy, and this can result in a shift in ideals, which impacts emotional self-efficacy, resulting in changes in their capacity for empathy. So, for example, as confidence increases, students can have more capacity for empathy. But on the other side of things, as emotional detachment increases, this can hamper students' ability to be empathetic. So, to summarise, students can have challenges understanding and communicating with people with dementia, and this can impact their ability to be empathetic. The clinical environment really shapes students' empathy and can challenge their moral values. Role models and ward culture are essential, but they're not equal. Positive role models inspire, motivate, and build confidence in students, but negative experiences lead students to feel the need to fit in and keep quiet. And this really, this has a huge impact on their ability to be empathetic. For students, there's a risk of emotional distress and dissonance as they experience feelings of frustration, anger, regret, and sadness in these types of environments. So we really need to ensure that we improve the environments in which students are learning in. And finally, cognitive and behavioural empathy are really important, and I think these are things that we can actually teach. However, there is work needed to support students to be able to balance the emotional load that they experience from empathy, and I think that can help us to improve empathy going forward. Thank you very much for listening.